I want him to hear what I'm going to say about him, right?
I can hear you, Mary Jo.
Oh, wonderful. All we see is your name up there, Michael. So it's good to virtually, we got a glimpse of you before they just put your name up. And I just wanted to say it is my great honor and deep, deep pleasure to be able to introduce our keynote speaker today, Dr. Michael McGinnis. Well, he currently serves at the National Academy of Medicine, where he is the Leonard D. Schaeffer Executive Officer, Senior Scholar, and Executive Director of the National Academy's Leadership Consortium for Public and Private Collaboration on behalf of a continuously learning health system. Well, I could go on for quite a while to list his many titles and jobs and positions over nearly 50 years, but I'm going to try to describe what he has actually accomplished and the kind of a person he is that helps all of us to lead longer, healthier lives. For me, Michael has the amazing and wonderful ability to envision a system-changing goal, get buy-in from all of the critical stakeholders, then create and nurture the needed policies and programs to implement the change, and then eventually he hands off durable structures to sustain the innovation so he can really make change happen. And he's best personally known for improving our understanding and insights into the basic determinants of health, which he was the first to identify back in 1993, over 50 years ago. He really reframed the notion of health from a view that was disease-centric to one that captures more broadly the full range of factors that lead to disease or to good health. And he served in HHS through 4 different administrations of both parties, creating the U.S. Preventive Services Task Force, the Healthy People Initiative, and the Dietary Guidelines for Americans, all of which continue to this day, and they started many of them 40 years ago. He's currently overseeing the Academy's work to identify investment imperatives for a healthy nation. And for me, it's interesting that one of the sub-goals is to meaningfully engage individuals and communities in all health-related decisions that affect them. Michael, welcome. We're glad you're here. Take it away.
Well, thank you, Mary Jo. And thanks to all of you for the opportunity to be with you today. But especially thanks for what you're doing. I would have done anything that Mary Jo asked me to do because she's such an incredibly committed person and leader. She even had me climbing Mount Kilimanjaro to wear a Healthy People 2000 t-shirt at the top. And that's just one of her many persuasive skills. But besides the fact that Mary Jo invited me, the fact is that you folks are serving DC, which is now my hometown and has been for over 50 years. And beyond that, you're really a national leader by example in bringing energy throughout our communities around the nation to bear in order to make a difference. And the difference that's going to be made in health and healthcare in this nation is only going to be possible with the commitment of groups and individuals who are part of the Villages movement. And that'll be clear in the course of my comments, which I will try to limit to around 20 minutes, and then we can have, or less if possible, and then we can have a general discussion. The title is The Role of Villages in a Person and Community-Focused Health Ecosystem. In this first slide you see, may not be able to see it quite as clearly as I can, but I'm going to start with it and then come back to it a little later. Of the way things we hope will be. Now, as you all know, because you've lived through it and many of you have worked in it, The health system is not a highly functional system at this point, health and healthcare system. And I'll underscore that as we go through some of the historical analyses that we've done here at the National Academy of Medicine throughout the pandemic, which we've all just coursed through. But here's a list of what ought to be the core commitments of the learning health system. We ought to, as citizens of this nation, as residents of this nation, we ought to have a health system and a series of healthcare organizations and agencies that ensure that engagement, safety, effectiveness, equitability, efficiency, accessibility, accountability, transparency, security, and adaptiveness are things that we can expect from the institutions that serve us. These are the core commitments of a learning health system, which serve as what we call a trust framework for the common good. And as I said, I'll come back to the importance of these and the importance of you and the villages community as eyes and ears to ensure that that's in fact what how we're being served by the various organizations that have been stood up to serve us. The next slide, please. If we can, there we go. Part of the definition and the identification of the core commitments of a learning health system come from the problems that we've seen, the problems that we saw in the crucible of the COVID-19 pandemic, in which we as the National Academy of Medicine were especially well placed by virtue of our having in our leadership consortium the leaders from 9 different sectors, the basically C-suite level folks who represented clinicians such as the AMA, patients, families, and communities, care systems, healthcare payers, both public and private, Medicare, Medicaid, as well as United Healthcare and the other large payers, public health, quality, safety, and standards organizations, research organizations, digital health, health product manufacturers, and innovators. Essentially, the dominant components of the health system ecosystem. And because we had the leadership of these sectors, we put them to work, each within their own sector, looking at the problems that were confronted during the pandemic that were unique not only to their own sector, but especially the specific charge was for them to look at issues in the health system writ large that were experienced in their sectors that needed to be changed. Next slide, please. So what we found was that in addition to the things that had to be fixed within each of the sectors, there were core problems that were common across all sectors. One was the issue of system fragmentation. The second was the issue of perverse incentives at work throughout the health system. The third was the issue of structural inequities and racism. And the fourth was mistrust. Regardless of the sector lens that was being used to assess the challenges that were brought out in full force during the pandemic, the issues of our fragmented system and the fact that we were spending money in the wrong places in order to have the outcomes we need, and the fact that there were intractable and indeed worsening inequities in play was brought home very clearly. At the outset of this activity, at the outset of the pandemic, we committed to following up on the analyses with the formation of a commission that would look at the challenges in greater detail and try to identify ways in which we could improve the state of play. Next slide, please. The commission that we formed, and I should say, actually, we had hoped that the commission of this sort would be stood up by either Congress or by the administration, a commission that looked broadly across all the factors in play in creating a fragmented, perversely incented system. But the challenges of that breadth have proved apparently, at least in that particular decision point, toward as the pandemic was winding down, left us with the task of taking on the broad issues. And so we formed a commission. And because the issues that we're engaging are so broad and so complex, and issues that we, as the National Academy of Medicine, felt we had an obligation to engage despite their breadth, we decided to do this in a staged fashion. So we first started by establishing a series of work streams, and you see them listed at the bottom here. A work stream on individual and community health goals, right at the heart of the role of villages. Engage, connect, and advance around individual and community health goals. How can we ensure that our health and healthcare system has that as the starting point for every decision? Secondly, a work stream on health financing and accountability in order to ensure that our financing structures are focused on services that attend first to individual and community goals. Thirdly, the digital and data architecture, which is the primary means that we have now of actually being a connected system, but it's woefully short of working in the way that it should. Fourth, the notion of inclusiveness and equity as a framing reference point for every decision that's made throughout our health and healthcare systems. And finally, the issue of the impact of private investments in health. This is an area that is only now becoming fully a part, at least in a cognizant fashion, of the health and health system, both from a contributions perspective, but especially at the moment of providing further distortions in some care delivery settings. And so the work streams that you see here are all identifying both the consequences of the inability to engage each of their arenas in an effective fashion, and looking at the levers that need to be engaged in order to enhance the alignment. The commission itself is charged with taking the reports of the work streams and recommending what it will take to actually align levers, laws, regulations, and culture that is now fragmented and move us into at least a better position in the community of nations, and certainly in service to our citizens. We are, despite having, as you all know, a $4 trillion investment in health that is 50% higher than the number two. We rank number 40 in terms of the outcomes and the health status of the people of this country. And we have actually, over the period of the pandemic and even a little into the period afterwards, actually suffered a decline in overall life expectancy. So the alignment that's necessary is clearly a major mandate for the nation. And we're looking forward to the recommendations of the commission, and in anticipation of the tough choices that they're going to place before Congress and governors and mayors and leaders throughout the nation, we've formed a couple of related coalitions. One is a philanthropic coalition in which we've worked with your local philanthropies that are funding a number of your activities in the villages community. We have about 400 local philanthropies that are getting ready to swing into gear when the commission makes its recommendations, and they're already giving us frontline views of what's happening in communities that represents dysfunctional alignment and the worsening of circumstances for those who are in outlier communities. Secondly, we've got a communication coalition that's also getting prepared for a major communications initiative when the commission wraps up its work. And so you see already that the size of the issues that we're looking at, where are our goals? How is financing structured? What's the digital architecture? How do we change our perspectives around equity? And what do we do about private investments that are sometimes distorting health? We need to have the demand function working in a very real fashion in every community and neighborhood throughout the nation. Next slide, please. So coming back to what we would like to see happen is to have every individual and every neighborhood group be aware of the extent to which those who are serving or putatively serving their needs are in fact providing services in which informed engagement options and choices are oriented to the goals of people served, in which safety of services is tested and updated by protocols to protect from unintended harm, in which evidence-based services are tailored to understanding of people's goals, that is, they're effective, they're equitable, in which there's parity and opportunity to achieve the desired goals, that they're efficient, optimal outcomes for accessible resources, that they're accessible, effective services, seamlessly available when and where needed, that they're accountable, and they're held accountable by every family and patient and citizen to the extent possible with the use of measures that matter, and that there's transparency, committed clarity, and sharing on activities, results, and the records of those results, that they're secure, especially critical in this time of a growing dependence on the digital infrastructure, and that they are adaptive, that they learn and change in order to improve the prospects. These core commitments, in effect, serve as a minor element, but an important element in our effort to rebuild the fractured system. If we can garner common ground in these core commitments, we can ensure that we're moving in a better direction. Next slide, please. This is my last slide. So the charge to the villages, the hope for the villages, is that you will serve as the eyes and the boots on the ground reporting on the engagement around the core commitments and on the alignment of our system players and stakeholders. So I'm going to stop there with great thanks for your existence, for your growing existence, and for your growing capacity to help us move in an effective manner to fix our broken health and healthcare system. Thank you. I think we have a few more minutes, so how would you like to handle the general discussion?
All right. Well, if any of our online audience has any questions, feel free to just use Q&A or chat. And then Mary Jo, I imagine, will make her way to the stage and field any live questions.
You're going to need someone with a microphone, so if you have questions for Dr. McGinnis, would you please raise your hand, and would some of our helpers, I already see one over in that corner there, and Steve, please feed them to us as you get them.
Got it.
Well, I just want to say I heard that we're the eyes and ears, and that you need our help as much as we need your help.
Thank
Oh,
you.
absolutely. Yeah, the fact is, I mean, we didn't have time to dwell on the forces at play in terms of the vested interests and so forth, but you know that they are substantial, and that the only way in which those forces can be actually aligned for good, as opposed to the current challenges to a functional ecosystem, is for the demand function to be from the grassroots, so that where there is legislation needed, there's air cover given for those legislators who want to do the right thing.
Question here.
Thank you. I was particularly moved by an article I read in MedPage by an ER doctor in the Asheville area who was talking about the difficulty of getting to everybody because of the climate catastrophe, but also getting to each person not knowing what their needs were before they got there. Did they have diabetes? Were they on dialysis? Had they been without medicine for X number of days? Did they have newborn children? All that stuff. How do you see, or do you see, the villages being part of a network that can help provide information during a climate catastrophe or other catastrophe to FEMA or any other resources to help people get the needs they have, because we know what our members' problems are?
Well, that's a really critical question, and very astute. And it gets both directly and indirectly at the issue of the potential power of those of you who are on the front line, because there's no technical reason that we can't have that information available at least electronically. Now, I realize that in Asheville, my daughter has a house in Asheville, so I'm very familiar with that, and indeed a house right in the epicenter of the storm there. She's fine, but they were cut off from communication of almost any sort. And that what that means is that there needs to be, and I'll oversimplify it, a two component capacity infrastructure. One is the electronic infrastructure that has that information available on every individual. The basics. It's the equivalent of having it all on your credit card. You know, we've talked about that possibility for years. The fact is totally possible if we can get the regulatory and the legal systems to drive that as a compulsory part of a functioning system. And secondly, the other element of the capacity is mobilizing, having neighborhoods be prepared to identify the likely sources of that information when it's cut off from the majority. So the way in which they can link to fire departments and police departments in order to ensure that they can reach individuals with the kind of information that should be available.
All right, Dr. McGinnis, we've got a bunch of online questions from our online audience. Lynn asks, are any national nursing organizations involved in your process, What about the area agencies on aging that are funded by the Older Americans Act?
Yes, we have actually a number of nursing organizations who are very much involved. The activity is overseen by this group of C-suite level folks I mentioned, including the American Academy of Nursing, the equivalent of the National Academy of Medicine. And also we have the ANA extensively involved. And by the way, I can't pass up the opportunity to say that I'm a very proud honorary member of the Association of Nurse Practitioners and of the American Academy of Nursing.
Wow. Let's see. Roxanne asks, what do you think the chances of Medicare paying for our services?
For
Villages.
you mean services the village? Well, you
Yeah.
know, I don't think that it's not out of the question, because we've already seen Medicaid and parts of Medicare in policy initiatives look beyond the clinic doors to the kinds of support systems that are necessary. And I'm quite sure that the commission, when it looks at the financing and accountability dimension, is going to say that our fee-for-service system, which is focused on widgets and not well-being, as it moves to a stronger focus on outcomes that matter for individuals, whether those outcomes are the product of something inside the clinic doors or of the partnership between what goes on inside the clinic doors and those outside the clinic doors, will be we'll be looking at ways to ensure that pooled funding streams can be applied more effectively. So I think that as a nation, we're clearly going to have to be more creative in that respect. Just to look at other nations very briefly, as you know, we spend 90% of our healthcare dollar on fee for service, basically, and much more, $4 trillion than any other nation. But if you look at the combined investment of all nations on issues of social services and health services, there are nations that outspend us. It's just that they spend more on social services. So hopefully we'll have a little redress there.
Okay. Let's see. Cynthia asks, I appreciate the potential for villages to be the eyes and boots on the ground. What is a practical forum or vehicle for villages to share what they learn?
Well, that's another important question. And I'm hoping that as we're rolling out the Learning Health System core commitments, and our plans are to build a website in which we can have a constant infusion of lessons learned about the effective work at the community level to improve the performance of our health institutions on each of those dimensions. But beyond that, it's going to have to be more than the National Academy of Medicine, obviously. And what it's going to take is every institution feeling that they have a stake in the game and that they're going to have as a source of pride the extent to which they are contributing to these common ground commitments.
Okay.
Thank you. I think Steve.
Yeah, I was going to say, we got tons of questions, but I want to pass it back to you all.
Right. I think we have one over here ready.
Sure. Thank you so much, and thank you so much for what you've presented to us, Dr. McGinnis, and particularly your mention about social services, which I'm sure you're talking about the much broader system. You know, housing is healthcare, food is healthcare, transportation makes healthcare possible. So, you know, when somebody says it goes without saying, you know, they're going to say it, so I am going to say it. Those things are all part of healthcare. Of course, long-term care, assisted living, caregiver support are all part of healthcare. And then, and last but certainly not least, when you talk about healthcare, we immediately go to doctors and hospitals, but we're also talking about, particularly for seniors, vision care, hearing assistance, and behavioral health services, which which are essential for healthy living at every stage of life, but particularly among older people. And so I just wanted to, as I said, goes without saying, felt like that needed to be said as well, that when we talk, and I know you're not just talking about medicine when you talk about healthcare, but just to make it clear that there's so much more that impacts people's health and sustainability. Thank you.
Thank you.
Yes, thank you for raising that. That's why we use the term health system.
One more.
Refer to health and healthcare, because as we've implied in the course of this conversation, and those of you who've heard me talk have heard me say many times, healthcare is only really accountable for about 15 to 20% of the avoidable deaths in this country.
We have time for just one last question, and we'll take it here.
This is a very impressive workflow that you have outlined. Obviously, a lot of thought has gone into this, but you also spoke about data collection. And in the light of the fact that during the pandemic, our healthcare system could not speak to each other. The CDC could not speak to the public health agencies. The public health agencies reported what they saw fit. Do you envision a place for artificial intelligence in both gathering the information that you're going to be generating and using it in the best way possible?
Well, there's no question about that. That's it. I could go on the artificial intelligence arena for quite some time because it's very exciting. Although there are also some potential pitfalls, which is why the National Academy of Medicine is at this, as we speak, developing a code of conduct for the use of artificial intelligence in health and healthcare. But beyond that, going back to the raw material, that is the data, our vision is for the positioning of health data, whether it's from healthcare or health insurance or companies or individuals with their handheld devices, to be positioned as a protected, well-protected public utility for the common good. We have, obviously, we treat water, we treat electricity, we treat gas as an essential utility for the common good. We have the ability to protect data, and we certainly have the technical capacity to ensure that we can, in effect, develop a virtual global clinical and health data trust. And we need to work hard to have that evolve. And clearly, when you're talking about data, there's absolutely going to be a need for a groundswell at the local level, a demand at the individual level, a demand for better use of your data, of my data, of everybody's data.
Thank you, Michael. So he's given us a charge. I think we walk away knowing that we are needed. Please don't go away, Michael. Let me see. I'm trying to change the slide. Can you help me with that? No, back. Just one. Oh, no, back. There we go. Michael, can you see my slide?
I can't.
Oh, well, I will.
No, I
read it to you.
can. Oh, yes, I see it now. Thank you.
Okay, so thank you. And I do want to read it because I want to say, in appreciation of your systems changing life's work, WAVE and the Village to Village Network would like to honor you with an award for your foundational contributions to helping older adults live longer and healthier lives and in creating a health ecosystem where villages are valued. Now, rather than give you something to hang on your wall or sit on your desk, and knowing your own personal generous habit of donating to charity in lieu of gifts, WAVE and V2V will donate $1,250 to the charity of your choice in your honor.
Oh. Thank you very much. I could not be more blessed at my association. Thank you.
Thank you so much. Thank you so much. Okay, now, getting back to earth a little bit here. We have 2 more afternoon breakout sessions, and they will, and you have all the information about it. Is there a big break? Is there 15 minutes between these 2 sessions? Or do people have to scurry between them? Well, watch